So T-cell lymphomas are a group of very heterogeneous disorders. There's now over 26 subtypes, and many of them have a very aggressive behavior. And usually what characterizes them is that they do not respond to cytotoxic chemotherapy, as well as the more common B-cell lymphomas that we are used to treating with cytotoxic agents. That is a problem, and usually a quarter to a third of patients are refractory to their initial therapy. And for the most aggressive T-cell lymphomas, unfortunately, we do see that 70 to 80% of patients will no longer be alive at 5 years after their initial diagnosis. That signifies a big need for new therapies. And immunotherapy is such a new approach that has the promise of really revolutionizing how we treat T-cell lymphomas. And we have several targets that we can attack and with immunotherapeutic agents. One of them is the obvious one, where we have most experience with, which is targeting surface antigens that are expressed preferentially in malignant T cells and not in the normal cells. That we can target, for example, with monoclonal antibodies, or we can target with immunoconjugates. We also now have trials looking at bispecific antibodies that target both the abnormal malignant T cells and then an immune effector cell, such as a normal T cell or NK cells or similar. That is one approach. Cellular therapy that can target surface antigens. The most prominent, of course, is CAR T-cell therapy. Is now under investigation in T-cell lymphomas. This type of therapy, CAR T-cell therapy, has been very successful in B-cell lymphoma and really revolutionized how we treat B-cell malignancies and offer the chance of cure to patients who otherwise had no curative options. However, we've been lagging behind very much in T-cell lymphomas due to several barriers, such as that when we make a CAR T-cell product that targets a T-cell, these CAR T-cells kill each other, which is from fratricide, which then can lead to a suboptimal product. The other issue is that when we target the malignant B cells, unfortunately, oftentimes there's a lot of collateral damage to the normal T cells. And while we are much better at treating patients who have B cell deficiency secondary to their lymphoma therapy, T cell aplasia, which means the absence of normal T cells, is not something that is easily addressed. So that's always a risk that we have encountered, but now we have had several mechanisms how we can overcome these obstacles. For example, by deleting the antigen that is being targeted, or by reducing its expression, for example. And several trials are underway targeting these surface markers such as CD30, CD5, CD7, CD70, etc. And they hold the promise of finally translating these advancements that we have seen in other hematological malignancies, also for patients with T-cell lymphoma, but we're still way off. And lastly, another way of immunotherapy in T-cell lymphoma is the use of checkpoint inhibitors. Again, there's different ways how we can do that, but essentially the principle is we activate an immune system that for some reason by the cancer has been put silent, so these cancer cells can escape immune surveillance, and we kind of unblock the mechanism that have led to that surveillance. And while there are some promising results, this is dependent, the responses are dependent on the subtype of the T-cell lymphoma and vary significantly, and certainly something that is under investigation, and several agents have been already looked at and have led to some promising responses, but combinations of immunotherapeutic agents and other agents that may enhance their efficacy, such as combinations of these immunotherapies with epigenetic therapies and other molecularly targeted therapies really hold the promise of changing the way we'll be treating T-cell lymphoma in the next, hopefully, 10 to 15 years.